Okay, now let's go on to postrenal acute kidney injury. So this is where both ureters get blocked, or the bladder can't empty, typically due to the prostate, or there's something wrong with the urethra, which would be pretty unlikely to have something wrong with the urethra. In women, the urethra is extremely short, so not much goes wrong with it. In males, sure, you can get scarring of the urethra from STDs, and then have difficulty urinating from that. But for the most part, it's usually an enlarging prostate that makes it very difficult for the patient to urinate, to get the urine out. And then there's backup of urine to the kidneys, both sides, leading to acute kidney injury, and elevation of creatinine and BUN occurs in the blood. Okay? So if you have blockage of one ureter, so say you have a kidney stone that travels down one ureter and blocks that one ureter, is that going to lead to increased creatinine and BUN in the bloodstream? Definitely not. You have a fully functioning other kidney, and that is more than enough to get rid of the waste products in your blood. So your creatinine and BUN would not be elevated in the setting of a kidney stone that's blocking the ureter in that's draining from one kidney. Okay. So let's look at the causes. So BPH is by far the most common. Now, stones I just mentioned, in order to have acute kidney injury, I mean, you could still have acute kidney injury on one side from a stone, right? So a stone that's blocking the ureter on one side will injure that one kidney, but it won't lead to abnormal BUN or creatinine because the other kidney can secrete it. Okay, so you can definitely still have an injury to the one kidney, an acute kidney injury, but it won't show up as abnormal blood tests because the other kidney can easily excrete BUN and creatinine. Okay, so you would have to be very unlucky to have kidney stones that are now blocking both ureters at the same time. Okay, that would lead to bilateral acute kidney injury and increased creatinine and BUN. Okay, so what are risk factors for kidney stones, by the way? So low fluid intake is definitely a risk factor because we tend to make little calcium deposits in our kidneys, right? There's definitely a genetic predisposition to forming kidney stones. African Americans are more predisposed to making kidney stones. Males as well are more predisposed to making kidney stones. So when you make a kidney stone and it's sitting in your kidney, it's not causing any problem until it actually leaves the kidney and travels into the ureter. And that's where all the problems begin. And that's when the pain begins because it's now blocking the ureter. Okay, so it's the blockage of the ureter from the stone as it tries to make its way to the bladder that's causing backup of urine and potentially acute kidney injury on one side. Okay, and you typically get a swollen kidney because the urine has nowhere to go. And we call that hydronephrosis, right? So hydro is water, nephrosis is swelling, so swelling, nephrosis is kidney, so swelling of the kidney. Okay? What else can cause post-renal acute kidney injury? Well, the cervix in women basically sits very close to the bottom of both ureters before they go into the bladder. So if you have cervical cancer and it's spreading locally, it can spread to both ureters and lead to complete obstruction of the ureters and backup of urine into both kidneys, and of course acute kidney injury from a post-renal cause. So in women, cervical cancer can cause this. In men, BPH would be the most common cause. Okay? Remember, a stone can block one ureter, but it's not going to block both ureters on each side at the same time. That would be extremely unlikely. Okay, so what are the complications of having a very enlarged prostate and now the bladder can't fully empty and the urine is not able to get into the bladder anymore and it's backing up through the ureters and back to the kidneys? Well, you get swollen ureter because it has nowhere to empty its urine. That's called hydroureter. And you get hydronephrosis, which is swelling of the kidney because of backup of urine. So the renal pelvis swells up. The calyces swell up because the urine can't flow through the ureter into the bladder. Okay, so let's go through the sequence. The blockage causes urine to back up to the kidney. So increased back pressure to the kidney causes dilation of the ureter, and then finally the renal pelvis, where the urine leaves the kidney, and then further back up into the kidney, called the calyces. That's going to cause more back pressure on the nephrons. That's going to lead to decreased filtrate that can get into the nephrons because there's just too much urine backing up, and that leads to a reduced GFR. And then if it's happening on both sides, meaning both kidneys, that's going to lead to increased creatinine and increased BUN, right? And it would happen on both sides in the case of BPH in men or metastatic cervical cancer, as an example, in women. Okay? And if it's left for a long time, the cells that line the nephrons will gradually start to die or lose the ability to function, and they won't be able to concentrate the urine. Okay? So all this back pressure is putting stress on the nephrons as well. So we'll talk about this further in the next slide. Okay, so let's look at a kidney stone here. Now remember, a kidney stone is not a issue that's happening on both sides at the same time, right? So you're not going to get changes in your blood BUN and creatinine from a kidney stone, but you will have an injury to that one kidney. Okay? Whereas when we're talking about BPH or a bladder that's not working well because you've had a spinal cord injury, such as a neurogenic bladder, and it doesn't empty well, well, those conditions are going to affect both ureters and back up to both kidneys. Okay? What about a pregnancy? Well, pregnancy often puts pressure on both ureters, and you can get a bit of mild hydronephrosis from the enlarging fetus putting pressure on the ureters and causing urine to get partially blocked. Okay? So BPH, again, a very common issue that can cause post-renal kidney injury. Kidney stones, I mentioned, that's usually unilateral, one-sided kidney injury. Not both sides at the same time. That would be very rare. Pregnancy can put pressure on both ureters and cause backup of urine into both kidneys. Urethral strictures, well, the urethra is after the bladder and after both ureters for sure. So that's definitely going to cause a backup to both ureters and cause hydronephrosis of both kidneys. and potentially increase BUN and creatinine. Okay. Tumors. Well, if you have a tumor that is affecting both ureters, that will lead to bilateral acute kidney injury. Okay. A neurogenic bladder from, say, a stroke or a spinal cord injury will cause both ureters to back up with urine and leading to a post-renal hydronephrosis and potentially post-renal acute kidney injury. Okay. Now, if you have a dilated ureters and urine that can't flow from the kidneys because of some blockage, well, that's a big risk factor for infection, right? So stagnant urine that's not flowing well to the bladder is a big risk factor for an infection. An infection in the kidney is called a pyelonephritis. Now, if you have BPH and you're not completely emptying your bladder, then you could get a bladder infection, right? Just a simple bladder infection because the urine is never being fully emptied from the bladder. Okay, so this next image is giving you an example of hydronephrosis, where you can see dilated renal pelvis, and actually you can see the major calyces where the urine comes into the renal pelvis, and that's very dilated. Okay, there's definitely a backup of urine into that kidney, and you can see that the ureter is very distended. It's not supposed to look that widened on this test, and this test is called an intravenous pyelogram, an IVP. We used to do this test a lot looking for a blockage, such as, say, a kidney stone that's blocked in the ureter. Okay, we don't use it as much anymore. It requires an injection of dye, and then it requires the dye to get to the kidneys, and then for the kidneys to take up the dye, and for the dye to get through the nephrons and flow through the ureter down to the bladder. So we really don't use these very much looking for a blocked kidney stone. We typically go right to a CAT scan. And a CAT scan will show us the exact same information, and also it will give us the size of the stone that's blocking the ureter. And here's what kidney stones look like. So kidney stones are called renal calculi, calculi for stone, or we call them urolithiasis. Okay, they all mean the same thing. So you can imagine one of these is sitting in your kidney, not causing any trouble at all. And then when it leaves the kidney, it travels down the ureter and causes intense flank pain on that side. Okay, and patients are usually vomiting. They're in severe pain. They often have pain that's radiating from the flank down into their groin, and often they have some bleeding with it, some hematuria, as the stone is going through the ureter. So very painful, and they don't need to be very big. They can often just be 2 or 3 or 4 millimeters, and they're very, very painful. The bigger the stone, the less chance that the patient will pass the stone by themselves. Okay, so as a stone approaches 10 millimeters, it becomes less and less likely that they're going to be able to pass the stone, and in that case they often need a urological procedure to remove the stone from the ureter. Okay, but we often give them time to try and pass the stone themselves. And of course these patients need painkillers, So they often need some kind of an opioid, and we also start them on anti-inflammatories because the ureter gets extremely inflamed as this stone is passing down it. Here's some examples of some other stones. So kidney stones are usually made of calcium. It's a mixture of calcium and oxalate. So we call them calcium oxalate stones. Or, and they're the most common, or they're made from uric acid. And if you remember, uric acid is that chemical, that molecule that's in our blood that can also lead to gout, right? So, and a flare-up of a joint from uric acid crystals. So if you have high uric acid in your bloodstream, you can develop gout in your joints, and you can develop uric acid kidney stones as well. So on the left, you'll see a number of kidney stones forming in each kidney. And these kidney stones, now this is an extreme picture. Most of the time, patients don't have this number of kidney stones in their kidney. But if you have kidney stones in your kidney, they don't typically cause trouble until they move and get into the ureter and cause blockage of the ureter and miserable pain. Okay, so isolated calcium stones in the kidney are not a trouble or are not a problem until they start to move. On the right, this is really one of the main treatments for preventing kidney stones: drinking lots of fluids, right? So when you drink lots of fluids, you get dilute urine. There's lots of blood flow to the kidneys, there's lots of urine being produced, and there's less chance of forming calcium stones or uric acid stones. Okay, so regular intake of fluid, keeping up with proper fluid intake is key to preventing kidney stones in the future. Now sometimes you can have an underlying condition that leads to stone formation, such as hypercalcemia. So if you have high calcium all the time in your bloodstream, you'll be more prone to forming calcium stones. And what could cause hypercalcemia? Well, if you have, say, a parathyroid tumor that's secreting parathyroid hormone and causing hypercalcemia, that could lead to kidney stones, okay? Or, as I mentioned before, elevation of uric acid in your bloodstream is also a risk factor for forming uric acid stones. Okay, so let's go through some symptoms of obstruction, okay? So there's many things that can cause your kidneys to become obstructed. And by far the most common is a kidney stone in one of the ureters, okay? So when we're talking about renal colic, that's exactly what a kidney stone that's in the ureter causes. We call that renal colic. And that is very classically presenting as flank pain with radiation to the groin and nausea and vomiting, okay? And when you have a kidney stone passing, you are unbelievably uncomfortable, okay? The ureter is in spasm because the stone trying to go down it. And you're often pacing. You can often tell when someone has a kidney stone because they're in the waiting room, walking back and forth, holding their flank, nauseated, sometimes vomiting. And it's a sudden onset, right? So it's severe pain that comes on suddenly with these symptoms. Now, if you have just a blockage of the ureter that's gradually progressed, and your kidney is just getting more and more swollen, that's just going to give you kind of a dull, achy non-colicky pain. So renal colic is a colicky pain. It's really uncomfortable, you're pacing, you can't sit still. Hydronephrosis, say from backup of fluid from BPH, you're not going to have that miserable pain that you have with a kidney stone. You're going to have more just a non-colicky, dull flank pain from the swollen kidneys. Okay? Now, if you happen to have bilateral obstruction of your ureters, that's where you're going to get into trouble with increased creatinine, increased BUN, because both sides are blocked. There's no ability to filter the urine or the blood on either side. Okay, so bilateral obstruction will lead to oliguria or anuria, meaning no urine at all, because there's no urine getting to the bladder. Okay, and that's not typically from a kidney stone. As I mentioned, a kidney stone is usually one-sided. That is more typically from BPH, or sometimes cervical cancer that blocks both ureters can cause bilateral obstruction. Okay. Now, say we discover the cause of the obstruction, and it happens to be an older man, and he hasn't been emptying his bladder for months, and he basically has backed up fluid to his kidneys. When we put a catheter into his bladder to drain his bladder, urine's definitely going to come out because he's been holding urine, and it's just been dribbling a bit every day. He's been holding urine for weeks or months. But now suddenly the kidneys have been released of all this back pressure that's now allowed to flow through a Foley catheter, and the kidneys respond with a diuresis. It's almost like all these nephrons just say, I'm so happy to be relieved of this back pressure that I'm going to make tremendous amounts of urine. And that's called polyuria, or post-obstructive diuresis. Okay? So, and tremendous amounts of urine can come out once you've relieved the obstruction, say with a Foley catheter, because the nephrons have been kind of stunned or injured for weeks because of the blockage, and now they're unable to concentrate and reabsorb fluid for a while because they've been blocked for so long. So the diuresis is due to the nephrons being unable to reabsorb fluid back into the bloodstream. And some patients can have significant diuresis, and it can be a bit concerning because the kidney is unable to reabsorb fluids, so they could run into trouble with dehydration or hypotension because the nephrons are just unable to reabsorb the fluid that's flowing through them. And this only occurs sometimes for hours or up to a day. It's not constant for a long time. Okay, so someone who's been blocked for a long time, and then we've reversed the blockage, they often end up with a post-obstructive diuresis. If you're blocked on both sides from a post-renal obstruction, such as BPH, you're going to have hypertension. Why? Because there's nowhere for the plasma volume to go. The urine's backed up to the kidneys, causing hydronephrosis. The blood flow that's going through the kidneys isn't being filtered anymore. And not only are you going to run into acute kidney injury, but you're going to run into hypertension because you're fluid overloaded, since you're not able to produce urine. Okay, so let's look at some potential diagnostic tests and as well as some treatments for conditions that are resulting in post-renal acute kidney injury. So the diagnostic tests are typically broken into three. We can use an ultrasound. What does an ultrasound show us? Well, we can look for hydronephrosis, we can look for hydroureter, we can look at the bladder to see if it's not emptying properly. Say, for example, in someone with benign prostatic hypertrophy, and they never empty their bladder fully of urine. CAT scans, again, CAT scan will give us information on hydronephrosis, hydroureter. It can actually give us the size of the stone that's blocking the ureter, that's resulting in renal colic. Okay. Sometimes we'll use X-rays, and X-rays aren't terribly useful, but sometimes we can see the actual calcified stone that's within the ureter. Typically, we'll use a CAT scan if we're looking for the size of the stone. Urinalysis just gives us a lot of information on whether there's an infection in the urine. It'll give us information on whether there's blood in the urine, which is very common in someone who's passing a kidney stone down their ureter. And the last test really isn't used very often anymore. It's called an intravenous pyelogram, and we inject dye into the patient, and the dye concentrates in the kidneys, and then we do multiple series of X-rays and watch how the dye travels through the kidneys, down the ureter, and into the bladder. Okay, I think there's a slide on an IBP. Okay, so let's look at some different conditions. So for kidney stones, someone comes in with an acute kidney stone that's blocking their ureter. Well, that's extremely uncomfortable and painful. So we typically use intravenous opioids or narcotics and intravenous non-steroidal anti-inflammatories. Okay, and the narcotics are really just to settle the pain, and the non-steroidal anti-inflammatory is to reduce the inflammation that's occurring within the ureter as the stone is trying to pass from the kidney into the bladder. Once the stone gets into the bladder, there's really no symptoms left, right? It's not passing through that narrow ureter anymore. Nausea and vomiting is very common with a kidney stone that's passing through the ureter. So antiemetics are frequently used. What about a stone that won't pass on itself by itself? So some stones, especially large ones, just won't pass to the bladder. So there's a few procedures that can be done. So lithotripsy is a procedure where they aim a beam at the stone, and the stone breaks into multiple small pieces that will then allow it to pass down the ureter and into the bladder. Sometimes cystoscopy is required, where a scope is inserted through the urethra into the bladder, and with that scope, a stent can be put into a ureter to allow proper flow of urine. Okay. Let's look at BPH now. So we spoke a bit about treatment of kidney stones that are trying to pass down a ureter. What about BPH? Someone who comes in obstructed, really unable to urinate properly because the prostate is so enlarged. So there's medicines we can use, and then there's surgical procedures that are available. So the medications are often what are called alpha-1 blockers. And you'll learn about this group of medications because they're also used as antihypertensive medications. But one of the effects of these drugs is that they relax the valve in the prostate, allowing for improved urinary flow. So these are often prescribed to patients that have BPH and poor urine flow. Okay. Transurethral resection of the prostate, a TURP, is a surgical procedure where a scope is put up through the penis, and the inside of the prostate where the urine flows, so the prostatic urethra, is widened. It's carved out a bit so that the urethra is wider through the prostate and the urine flows much better. Okay? And a Foley catheter is sometimes used when someone comes in and they're just obstructed. They're unable to urinate, right? So it's not like they can immediately go for a TURP. So we insert a Foley catheter to allow the drainage of urine. Okay. What about a cancer, such as a cervical cancer that's blocking or has spread to the ureters? Well, that typically needs chemotherapy, radiation, and surgery. And the surgery is not only to try and remove parts of the cancer, but it's to repair the ureters that are damaged by the cancer, so the urine can again flow. Okay. And lastly, another example is an atonic bladder. So say, for example, someone's had a stroke or a spinal cord injury, and the nerves aren't working properly to the bladder. They're not causing the bladder to contract, or the nerves that are sending signals to the brain in terms of how full the bladder is are just not functioning because of some kind of injury, such as a spinal cord injury. Well, those patients typically need regular catheterizations, so they need to do their own catheterizations throughout the day to keep their bladder empty, right? So some patients may have to self-catheterize 2 or 3 or 4 times per day. Okay, so I hope that helps. Just understand that there's different treatments for post-renal AKI, and it's really trying to relieve the obstruction depending on what it is. So a kidney stone, okay, there's a set of treatments for that. BPH, there's treatments for that we spoke about. And finally, atonic bladder, meaning something's happened to the nerves to the bladder where the body can't sense the filling of the bladder. Well, they will likely need regular catheterizations at home or a visiting nurse to make sure that their bladder isn't constantly filled with urine. Okay, so how do we prevent all types of acute kidney injury? Well, if it's a pre-renal problem, such as dehydration or hemorrhage, or say you have a severe burn and you're hypotensive, well, anything that's pre-renal is going to result in low blood flow to the kidneys. So how do we avoid a pre-renal injury to the kidneys? Try to avoid hypotension by giving them fluids, right? If the pre-renal issue is sepsis, well, we give them lots of fluids plus antibiotics to treat the bacterial infection. If it's heart failure, well, we try and help the heart with medications to beat with more contractility to increase cardiac output so the blood flow to the kidney improves. So it's all about improving blood flow to the kidney. With intrarenal kidney injury, well, we're going to try and avoid nephrotoxic drugs, right? And because they're going to directly harm the nephrons. We can treat nephrotic syndrome or nephritis, glomerulonephritis, with an assortment of different medications. So intrarenal kidney injury is usually either prevention of certain drugs, such as non-steroidal anti-inflammatories, or vancomycin, or aminoglycosides, or treating the underlying disease that's injuring the kidney, the nephrotic syndrome or the nephritis. Okay. The post-renal prevention is, well, you have to relieve the pressure. Okay, you have to deal with the obstruction. So if it's BPH, well, sometimes we need to put a Foley catheter in for a period of time. Sometimes they need a surgical procedure to open up the inside of the prostate, to core out the inside so that they can urinate better. Okay. If it's cervical cancer that's blocking both ureters, well, that's going to need surgery or radiation or chemotherapy. So it really just depends on the underlying cause. Okay. With post-renal blockage, there's a lot of urine that's just not moving. So anyone who has a post-renal issue is going to have stagnant urine, and they can get UTIs. We treat those with antibiotics. And we definitely monitor the urine output in any of these conditions. Okay, pre-renal, you're not making much urine. So we want to give you fluids to see that you will start to make urine. That's really important. Intrarenal issues, you may have oliguria as well. So nephritis, nephrotic syndrome, nephrotoxic drugs, they can all injure your kidney. We're definitely going to monitor urine output. Okay? So any of these conditions require monitoring of intake of fluids and output of urine, and very frequent waits in hospital, typically daily waits in hospital, to see what's happening with the fluid. Because when you're losing or gaining weight on a daily basis, it's always going to be fluid, right? So you don't gain weight in a day from fat or from protein. You gain it from your fluid status. So monitoring input and output is very important. Okay, so let's talk about some signs and symptoms that are associated with the different types of acute kidney injury. So if you're pre-renal, it often means that you're hypotensive and poorly perfusing your kidneys with blood. So your urine output is going to be diminished, reduced, right? Your kidneys are going to want to keep all the fluid that's coming to them by reabsorbing it. Your blood pressure, often hypotensive, right? That's the underlying problem with pre-renal issues. Heart rate, typically fast, tachycardic, trying to maintain that blood pressure and blood flow. Perfusion status, well, you're often not perfusing your organs if you're hypotensive. So your skin might look pale. You might be confused because you're not getting enough blood to your brain. Your heart is racing to try and keep up with the low blood pressure. Your kidneys are going into pre-renal kidney injury because of the low blood pressure. Your BUN and creatinine are going up. They're increasing, right? Those are waste products, and the kidneys are not being perfused properly, so they are going up in the blood stream. So when we check them, we fully expect BUN and creatinine to be elevated in a pre-renal acute kidney injury. Okay, very concentrated urine because the kidneys are doing everything they can to keep the fluid in the body with ADH and aldosterone. A very high specific gravity in the urine, right? It's really concentrated dark urine. Hyperkalemia. Why hyperkalemia? Because the kidneys are failing and they're not able to get rid of potassium that's being made in the body. Okay, so that's an important issue with any renal failure, is hyperkalemia. Metabolic acidosis, again, because the acids that are being made in the body aren't getting properly to the kidneys to be excreted in the urine because of the poor flow to the kidneys. Okay. What about intrarenal injury? Say from a drug, or maybe from glomerulonephritis. Well, again, elevated BUN and creatinine, right? Waste products that are going up in the bloodstream. Oliguria, because the kidney's being injured by a drug or by a disease such as glomerulonephritis. The plasma volume is overloaded because the kidneys aren't making urine properly, so reduced production of urine. Hypertension for sure, again, because of the volume overload. Proteinuria, hematuria, that can occur in, say, for example, a glomerulonephritis or a nephrotic syndrome. Nephrotic syndrome, 3.5 grams of proteinuria. Nephritis, glomerulonephritis, that is, you're losing proteins, you're losing blood cells through the glomerulus. And of course, because the kidneys aren't producing urine, you can definitely get hyperkalemia and metabolic acidosis as well. What about post-renal failure? Well, if you have post-renal failure, such as BPH, well, you're not going to see a lot of urine because it's not emptying from the bladder. In fact, it's backing up into the ureters and causing hydronephrosis at the kidneys, right? So urinary retention is a hallmark of BPH. You're unable to empty your bladder in BPH. Hydronephrosis, again, because of the backup of urine to the kidneys, and now you get swollen kidneys. And of course, again, elevated BUN and creatinine, since both sides are affected by a prostate blockage or, say, a bilateral ureter obstruction from a cervical cancer, your BUN and creatinine are going to be elevated in your blood. Hyperkalemia and metabolic acidosis, again, that's going to occur because the kidneys are not making a lot of urine and they're just not able to secrete and get rid of the potassium and the acids. Okay, so let's talk about the 3 phases of acute kidney injury recovery. So you have your initial oliguric phase, where there's been retention of blood urea nitrogen, potentially potassium in the bloodstream, increased creatinine, which is another waste product, and we call this uremia. When you have elevated BUN and creatinine, we call this uremia. The patient is uremic. Okay, and they also have edema, right? They haven't been able to make urine. Now, this is going to be different depending on what type of kidney injury has occurred, whether it's pre-renal, renal, or post-renal. Okay, so let's say it's just a renal injury. Well, you're going to have edema around the body because you're not making urine. So you could have pulmonary congestion, meaning fluid going onto the lungs. You're going to have swelling of your feet, swelling around your eyes. So all of those things can happen. Okay. So as the kidneys begin to fail more and more, and you become more and more uremic, meaning increased BUN and creatinine, you're going to have fatigue because you have waste products in your bloodstream. You're going to have lethargy. Somnolence is another term for just fatigue. And if your kidneys continue to fail, you're going to run into all kinds of electrolyte problems. And the biggest one is hyperkalemia, right? Because hyperkalemia is deadly to the heart. It causes very dangerous arrhythmias of the heart. So uremia can lead to a coma because your brain is now being perfused with blood that's full of waste products. And finally, death will occur, and it's typically from hyperkalemia. that causes a cardiac arrest. Okay, so the oliguric phase is just dependent on what's causing it. Okay, now if it's a pre-renal issue, are you going to have edema? No, right? Because you're hypotensive. If it's a renal issue, are you going to have edema? Sure. If it's a post-renal obstruction, are you going to have edema? Absolutely. Okay, because everything is backing up. So really in pre-renal kidney injury, you're not going to have any edema or anything like that, because it's just the kidney injury is because of lack of blood pressure. Okay, now let's look at the diuretic phase. So the diuretic phase is where you start giving, say, IV fluids for a pre-renal issue, or even IV fluids for a renal issue. And the kidneys start to wake up, kind of like watering a flower. You know that dead flower you have in the corner of your house, and you give it some water and suddenly it wakes back up? Well, that's what kidneys can do. So we give them IV fluids, and suddenly there's a diuretic phase because the kidneys have sustained an injury, right? And the nephrons have gone into a bit of shock, and now suddenly we're giving IV fluids. And they don't have the ability to work that well, so they can't reabsorb a lot of fluid. So they just make tremendous amounts of urine because they've lost the ability to concentrate for the first few days to weeks. Okay? And the diuretic phase, as I mentioned on the other slide, can lead to hypovolemia and hypotension because so much fluid is lost in this phase. And we have to keep up with that fluid loss with more intravenous fluids. So that's where urine output becomes really important, so that we can monitor how much they're urinating out and how much they're getting in. Now, the serum creatinine and BUN often remain elevated. Why? Because the kidneys are still in a bit of shock. The nephrons are still not fully functioning yet. And the collecting duct, as I mentioned, is just not able to concentrate the filtrate and turn it into concentrated urine. So the diuretic phase is really where you're just producing a tremendous amount of urine because the kidney sustained a shock, whether it's a pre-renal shock, a renal shock, or a post-renal shock. The recovery phase is where the nephrons have repaired themselves. They're able to concentrate urine again, and the urine output is now returning to normal, which is typically about 1 to 2 liters per day. And your BUN and creatinine start to normalize and go back to normal levels. Okay? So if you have a significant acute kidney injury, sometimes the BUN creatinine just never go back to normal because the kidney took such an injury that some of the nephrons just died, and then you're left with a slightly elevated BUN and creatinine. But typically, if they receive IV fluids and they're treated properly, the recovery phase results in a normal BUN and creatinine. So the kidneys are pretty tough that way. They can recover. Okay, so here's a question. Which type of acute renal failure will be most likely to accompany benign prostatic hypertrophy? So I know on these slides I purposely try to be repetitious because I really think that's how many of us learn, by just hearing something in a slightly different way. Okay, so I'm expecting you to understand this one because I know I've said it in multiple slides. So BPH, well, that's prostatic enlargement. That causes backup of fluid into the ureters, and then finally hydronephrosis. So that is a post-renal acute renal failure, right? It's happening after the kidneys. So pre-renal, anything before the kidneys that's causing the kidney injury. Renal is anything that's within the kidneys, or another term for it is intrinsic. Post-renal is anything that's happening after the kidneys, such as the ureter, the bladder, or the prostate.